Many thanks, Selena. That was a wonderful presentation. The floor is open for discussion. If people have questions or comments, please feel free to make them now. Maybe I can start by commenting on one element of your presentation, Selena. It was kind of interesting to me, the notion that as we develop more and more tools, the interoperability between these tools becomes a very critical question. And I don't actually know how that's being done, or whether there's work that's being conducted. Certainly in the technology field, there's a lot of work to ensure interoperability, but in the area of devices and robots, I can imagine that without some sort of master planning and interoperability planning, we could end up essentially with a dysfunctional system. So is that something that you're trying to address in Singapore, Selena?
Absolutely. It's like urban development. If we don't plan ahead, you are quite correct to say that it's not just inefficient, but actually much of our work is data-driven. And many speakers in the workshop from day one and even today talk about how data is absolutely important in our work. And in order to collect data, we need the systems to talk to each other. We need the system to be interoperable. But so beyond effectiveness, we do need this to create interoperability platforms to allow the various different types of technologies, be it IT, IoT, ICT. I can go on in terms of the abbreviations, but they need to be able to operate so that our staff don't end up, instead of looking after patients, looking after machines.
It seems to me that in an integrated health system, it's possible to do that, or an integrated care system. Perhaps NHS or something like that could do that. But in the United States, where there's a complete balkanization of health, I don't know how that gets done. And especially since each company that's developing these tools has their own perspective of the world and doesn't necessarily care or want interoperability with others. And I don't know how we solve that problem except at a very high policy level.
That is both a gap and an opportunity for us, I believe. In that it is just like how we solve traffic issues by having a highway code. We do need to come together as a global community to say, look, if we want to fight this problem together, we all need to have an understanding or a treaty for that word, where we can all come together for the devices to interoperate, the devices to share data so that we can then collect that data and analyze it and allow for it to create more value for us. And this needs to be planned ahead. This needs to have a lot of lobbying amongst the device makers, the IT solution makers, and agree that the way forward is not just proprietary, but there must be a route to allow everyone. You can drive different cars, but you must obey the same traffic system. That's an opportunity for us.
Thank you. Elena, you had a comment?
Yes, I wanted to contribute to that, because I think that a lot of progress has been made also, and particularly actually in the US, in terms of mandating the interoperability of electronic health records and technology solution. One of the key elements is really being guided by clear standards. So FHIR, the Fast Healthcare Interoperability Resource, which is actually a standard that describes really data formats, right? And then it interacts basically with an application programming interface that does a sort of lingua franca where data can be exchanged, not only between different data sources, but also application. If you procure really for interoperability, I think that is the way forward. And there needs to be a rebuilding or redesigning of solutions to the core, which are standard-based, open, and interoperable. If not, we're going to limit the type of innovation that can be done. And actually, there are, we went through that journey. It's an investment. You have to reconceive your tools to comply with these standards. But once you have done that, from the standard, you can basically manage services with a collective ecosystem of medical devices through managed services that are enabled by FHIR standards. In Europe, we have FHIR, and we have also open EHR as another emerging standard. But I think there is a way forward that we are starting to see if governments procure that way.
Thank you. Mark?
Yes, I would agree. I was going to actually mention the FHIR standards and also the US CDI standardization of data in the US, and several efforts here in the US from both the Office of the National Coordinator of Health IT as well as CMS, the Center for Medicare Services, in terms of some regulations stemming from the 21st Century Cures Act that mandate on especially healthcare providers who received health IT adoption incentives to exchange data. But I think where we're lagging is we're still in a looking at aging care in a siloed manner, right? We're looking at it as acute care. For example, in the US, we incentivized acute care providers, hospitals, and physicians to adopt electronic health records. And we left out the behavioral health providers, we left out the therapists and long-term and post-acute care providers, right? So we're still trying to, because we did not invest in the same way in the US, we're still trying to put band-aids to encourage the adoption of similar standards on the long-term post-acute care side, and also to put the right incentives, meaning quality measures, the electronic quality measures that are tied to the standardized data elements that we're collecting, and having the appropriate payment modifiers and the alternative payment systems that not only encourage upgrading to those standard-based interoperable tools, but also incentivize the ongoing use and meaningful use. Now, I'm not using it in the meaningful use in terms of exchanging data with the broader healthcare team, which should include those that are taking care of social aspects, right? Social determinants of health, from housing all the way to social engagement and quality of life aspects, as well as appropriately coordinating care, reducing redundancies, and so on and so forth. So I'll stop here.
Okay, thank you. Linda?
Thank you all so much. This is really a powerful discussion. I want to add one other question to the mix, which is perhaps even more difficult to figure out how to solve. For the NAM Commission, where we are seeking to create a vision not just for interoperability and issues of delivering better health now, but trying to create a future-back vision that's evidence-driven about what might be possible in the future to create healthy longevity. what I hear across every one of these very fabulous 4 sessions is the need to really think about the complex system of all the different levels of societal change, of social context, of technological change, and the huge transformations that are here and coming in terms of scientific capabilities and understanding. How do we actually create a system that works together so that the transformative possibilities can be harnessed in combination optimally?
Yeah, Linda, I think there's another element to it, perhaps that I can throw out there. In medicine, of course, you have monotherapy, and then you have combination therapies. And it's incumbent upon you to show that the combination is better than the monotherapy. And so this applies, I think, also to technology, that if we do have platforms that allow us to combine technologies, we should also be able to measure that the combination is better than the individual part. And so it raises a whole issue that I think Omer Inan mentioned in the previous discussion about, what is the difference between a toy and a true device, and how do you measure it, and what is the regulatory means by which that gets approved? And I think we should really endeavor in this space to go beyond interesting, possibly effective, to one of proven efficacy and combination efficacy that exceeds mono application efficacy, and that will then, I think, create an incremental improvement in healthy longevity.
And
anyway,
if I could add one thing to what you just said, I would say that the nature of a complex system, and I've heard so many people make this point, is that a solo intervention may not be successful unless it is implemented in combination with the other with the other interventions. That's the flip side of what you just said, Taji, but that requires new methods of assessment so that we don't decide that an intervention failed when it wasn't in the right context.
Yeah, well, this is absolutely the case with medicines. Many medicines as monotherapy don't work, but as combinations do. Right. But anyway, John, you're next.
Yeah, thanks. And actually, I think it follows on very well from what Linda is saying, and also what you mentioned a moment ago, which is the balkanization of healthcare delivery in the United States. And I think also touches on what some of the speakers today and yesterday have been speaking of. With the Commission, we've been tasked with being very ambitious, with thinking forward to 2050, and then trying to look back to what we should be doing now to create a better 2050. 2050 is 30 years away. There's a lot of change that's going to happen. And as I look at the discussion, a recurring problem that seems to be a barrier to us being really transformative is that we seem to consistently define healthy longevity through the lens of the absence of disease. And I heard yesterday Eric and Nur and a few other people talking about their frustrations, for example, with the TAME trial, not being able to get funding unless it was aligned to disease. And yet, as Eric said yesterday, our framing of disease is centuries old, and we're now in a space with AI and the data we're collecting that I actually believe we can move ahead of that and start to frame our perspective of healthy longevity from the perspective of functioning. And it's been done before. Linda, you did it with frailty and a phenotype for what frailty is. there's no reason why we can't have a phenotype for what healthy aging is. And I'm not just thinking here at a cellular level or biomarkers. I mean, what if you ask an older person what's important for them, it's the ability to be and do things. It's not whether they've got disease or not. If you can have diabetes, but if you're given metformin, you've got greater longevity than somebody who doesn't have diabetes. You know, the thing that's important is capacity, and things like cognitive capacity, locomotor capacity, vision, hearing, psychological capacity, these sorts of things. And I think it's time for us to move beyond disease and start framing those as the ultimate outcome. And if we do that, imagine how we could design a health system where the financial incentives are to improve capacity, not to respond to disease, not to respond through process, but financing and the whole orientation of the system would be about trying to improve somebody's capacity to be and do the things they value. So I am just wondering if other people are as frustrated as I am by this current lens, and if they have some ideas about how we might be able to move forward.
I'm sorry, somebody has a phone ringing in. If you could just mute your mic, it would be helpful. Thank you, John. I think Sachin was next.
Thank you. I'm really enjoying this discussion. And so far, we have been mostly discussing what we can do to the patients. And actually, the goal is to move from patients to participants, to recognize the individual. Also, to create a culture of healthy longevity, we need two important components. One is patient or participant education. Are individuals really eager to live long? And there is some Nelson surveys showing that nearly 40% of adult population in the US alone, they actually don't want to live long. They want to enjoy what is there right now, eat, drink, have a lot of fun, and maybe even die early. So I guess there is a need for empowering patients with the knowledge of the benefit of living long, a living long, healthy life, and then create opportunities so that they can achieve that goal. Most of the stuff that we have been discussing is about medicine. But if we think about a patient's interaction with a doctor, that happens maximum an hour in a year. And the person has to live another 8,700 plus hours in a year, all by himself. So that's why we're going to think about what are the 5 or 10 or simple few dozen health education and empowerment tips. Somehow we can give to every participant so that they themselves will be eager to live longer, a healthier life. And that way we can create the culture of healthy longevity. So that raises another question. So that is, when the person is living 8,700 hours by himself or herself, then those days are mostly spent living with healthy lifestyle, with some interaction from medicine. So understanding how lifestyles interact with medicines or pharmaceuticals or nutraceuticals will become even more important. So those were my comments. Thank you.
Thank you, Sachin. Beth, I believe you were next.
Terrific. And I'm just so pleased by the trajectory of these comments of not only having a systems perspective and looking at meaningful quality of life as outcomes, but building on what Satya was saying, that this is a source for intervention, right? These are not only outcome measurements, but what are the interventions that we can create in the home, in the family, in the community that build and extend meaningful aging. And so many of the technologies and so many of the ways that our lives are currently scaffolded create unnecessary barriers to meaningful participation. And I want to close on another point, which is that this is not just an opportunity for technology and design and a more holistic opportunity around healthcare, but this is going to also reflect in reimbursement policy. So even if we look at, I can see Maj and I have talked about this, even if we look at the reimbursement around a wheelchair, is it medically necessary? You know, is it around medical necessity to get from the bedroom to the bathroom to the kitchen? Or is it based on being able to engage with the community, to have sufficient battery life, to be able to get in and about for the day? We have, in the US, we have drastically different reimbursement systems, whether you're on Medicaid, Medicare versus the VA, because our reimbursement is on medical necessity as opposed to meaningful engagement. So we need the systems perspective to go holistically across all aspects of engagement with the healthcare system for meaningful aging, not just medically possible aging.
I think I agree with you, Beth. And one of the interesting elements of it is that in order to have true evidence of impact, there have to be surrogates, because we just can't do 10-year studies to see whether there's an impact on longevity, for example, or health span. But it's incumbent on us to find surrogates of impact, or biomarkers, or whatever you want to call it, so that in a shorter period of time, we can have a clue as to whether the intervention is going to have an impact over time. And that's a very complex problem and a challenge that I think society faces.
Agree. We need this chain of evidence. Agree very much.
Right.
Thank you.
Victor.
At the next, we have a committee on emerging technology, science, and innovation. Kaushik is a member of the committee. I see him on the Zoom here. And I want to point out that when we looked at technologies, and we presented to Eric Lander, the science advisor Biden, he called us a technical optimist. And that's what I heard. All the discussion today is all the upside of technology. And I don't want to be a skunk in the party. However, I do think that, Linda, in your report, you have to also think about the other side of technology. So many unintended consequences, as you can imagine, in terms of artificial intelligence, the biased data, cyber security, and so many others. So we do want to be sure that as we think about technology for the elderly, we think about the safeguard, if you will, of the technology, and that's being used effectively and to that advantage, and not being misused, abused, or even, have negative consequences. So I just want to add that into the equation, Linda and John, in your roadmap, because I think I'm a strong believer of emerging technologies. But as Kaushik and I have been working on for almost 2 years now with this committee, there are many societal implications of technology. And those things have to be discussed. And we are trying to create a governance framework where multi-sectoral aspects, of technology and its effect on society is addressed as well. Kaushik, you may want to say a word about this.
Sure, thanks, Victor. There's so much to say that I'm trying to think about where to come in on this. And the one thing I thought, I was thinking about here is the sort of tension between prolonging life and improving the quality of life. Because on the one hand, sometimes they go together, but sometimes they also pull in different directions. And aging is a biological process, but healthy longevity is a social condition. And so one of the things that I was thinking about as I was hearing these really wonderful contributions is what parts of responding to aging can be medicalized and what parts of it can't be medicalized. And I thought that the conversation on loneliness in the last panel, for instance, was really interesting and pertinent there, because that could lead to a whole series of conditions that could be responded to by medicine: anxiety, depression, the effects of 11 cigarettes a day. But loneliness in itself is a social condition. And one of the things I was thinking about then, as we think about the social contexts, and we've talked a lot about uneven or unequal social contexts, and some of this inequality is because of resource lack, but some of it could also be about other situations of social anomie that are not just about resource lack. And in terms of gaps, maybe the one thing I wanted to introduce that maybe we haven't talked about that much is what does it mean to age in a time of environmental crisis? And so I've been thinking a lot, for instance, about getting old in Delhi these days, where the air has become unbreathable. Perhaps the single technology that's most essential for healthy longevity is an air purifier. And so when we think inequities, the sort of mapping of that is also complicated. It's not just global north versus global south. It's the north side of Chicago versus Gary, Indiana. It's Newport Beach versus Tustin. And so aging in a cancer cluster is not the same as aging in a place where you get good water. And so I'm thinking here about the situations when we think about the social implications here and governance frameworks. What about those situations where aging is not always a function of a lifestyle choice, but a function of the environments in which people live?
Okay, thank you very much. I think it's Colin.
Yes, thank you. Very exciting discussion, of course. I do want to say that it's really important to think about aging as not a single thing. It's multiple processes resulting from multiple genetic, epigenetic, and environmental processes. And therefore, interventions will be geared toward addressing those very many pathways and targets that contribute to aging and decreased longevity in specific individuals. So we need to think about precision aging, just like we have personalized and precision approaches to multiple other diseases, particularly cancer. There are many different interventions that people are talking about, from metformin to rapamycin to autophagy enhancers. They're going to be effective in individuals that are prone to aging due to some kind of a deficiency in those pathways. So we need to both power future studies to identify predictors of response and really develop a host of interventions that we can personalize and customize and create a precision approach to the very different types of aging, which are particularly different among ethnic groups. I think that one concerns that I have is that many of the studies that are emerging are going to be done primarily on Europeans, people of European descent, and may not be applicable to other races, Asians, Blacks, and Hispanics. So we need to think about those perspectives when we're looking at new approaches.
Thank you very much. Michelle?
Many older adults with disease will need support from caregivers, whether it be family, friends, or paid caregivers, and some technologies allow for sharing digital data. In my practice, people with diabetes use continuous glucose monitoring data and then share that data with someone using a mobile app. And Sachin brought up the importance of health education, and I would argue that this education needs to expand to caregivers. Some family members are just not adequately trained or equipped to know how to respond to this data or help the person wearing the device respond to this data. So we need an infrastructure to support this education. And then considering the flip side, we need to consider how the older person's privacy and the fact that they actually may not want to share any data at all or only certain portions of data.
Thank you. Rita?
Thank you. And we've talked quite a bit about the importance of evidence and standardization. Our evidence, however, is relevant largely to the majority, and the forms of evidence and standardization prioritizes the majority. I'm worried about outliers, minority, the exceptions. If we standardize on efficacy for the majority, people that are marginalized will become even more marginalized. So it isn't just a risk of technology, but how we prioritize, design, and determine the standardization of that technology. I'd love to hear from our speakers regarding how we address that. And it goes beyond what we have talked about in terms of AI bias or AI ethics, where we're concerned about data gaps or human biases finding their way into the algorithms. It is an artifact of our probabilistic means of making decisions, determining things through average or statistical significance rather than considering the broad spectrum of diversity.
A very complex topic and applies to all areas of statistical analysis. Certainly in pharmaceuticals, this is always a problem. And you know, I'd be interested to hear if there are experts on this area in the room that might comment here. Anyway, if you have any ideas, please send them in. Joshua.
Hi, thank you. And again, today's discussion has just been superb. I wanted to comment on something that was mentioned by several speakers over the last few minutes, but particularly John Beard, about how we define what a phenotype might be, defining it from the point of view of what I guess we could term resilience rather than dysfunction. The International Society for Frailty and Sarcopenia has published quite a few position papers on measures that can look at functional performance, and some of them are rather rather simple to make. Things like how fast a person can walk in 4 seconds, or the 6-minute walk speed. So these are very easy to measure. The tie-in with technology is to wearable devices, and how easily we are now going to be able to make these measurements in real time from individuals. Just a person who just has a phone can, that phone can provide retrospective, very powerful data on functional capacity. The challenge again is going to be working with regulators to get approval to use pharmacologic or biological agents, which I think many of us on this call are focused on, that the idea that we can biologically intervene in addition to the other, you know, in addition to all of the other technical and societal approaches that are crucial. But I think we've got a big problem here that needs to be solved with the FDA, with the PMDA in Japan, with other regulators, funders of research, so that we can streamline and get through this valley of death, that we can get some of the safe and effective and products that are out there into use. Thank you.
Thank you, Josh. Elena?
Yes, thank you. 2 comments. First of all, in several contributions, the perspective of the ecosystem, really of the system thinking around aging and around healthier longevity has come up. And in a way, you know, even if we put all technology solutions that are appropriate, if, for example, we cannot make the connection between scheduling an appointment and then making sure that we book the right transportation, or making sure that services are more easily accessible, right? All of that will break down some of the innovation that we are trying to bring to the forefront. So in a way, it's really a call for an integrated policy look across, is it transportation, food, culture, intergenerational support. We really need to take a system approach, not to be leaving our innovation that collectively we are trying to bring to the population, really being stuck in silos. And the second point is that we talk a lot about what we can do for the people, for the citizens, even before they become patients. But we really need to remember that the burnout in clinicians is really very, very, very strong. The gap that I mentioned in the presentation has never been so strong in terms of the need to really step up and almost not being able to address what we need to address for a healthier society tomorrow. So we really need to consider, when we do policies, also how do we alleviate and liberate productivity for those that have to care for the elderly people. Because if not, we're going to put even more pressure and really not reconcile the two parts of the coin. Thank you.
Thank you. Actually, I was actually thinking about Juta's question, which has to do with measurement of efficacy directed really at the mass and not at the minority populations. And the solution to that in medicine anyway is moving towards precision medicine, where you can identify subgroups that will be smaller parts of the whole that will respond better to certain interventions as opposed to others. And I think to the degree that we can identify those subsets of aging populations with common characteristics or genetics or other biomarkers that define the minority subsets, then I think it's possible to create specific measurement tools for them. And I think we're actually a bit removed from our ability to do that yet, because we may not have enough phenotypic information to combine with genotypic or polyomics tools to find those subsets. But as they arise over time, and will happen as much with artificial intelligence as anything, we'll be able to identify those subsets and create specific markers for efficacy in those populations as opposed to the larger whole. I think this is a very complex problem that requires addressing over time. Sachin?
Yeah, thank you. Wanted to bring up another point about technology, AI, engineering, etc. From basic biomedical research, in basic biomedical research, you just mentioned multiomics is a new approach where we are figuring out molecular interactions within a tissue or cell. Now, but biologists, we know that these interactions and these molecular states change over time, over circadian rhythm, or estrous cycle, seasons, or even aging. And tissues interact with each other. And from engineering, we know that engineers make multiscale models to figure out how the aeroplane will fly. So now there's a unmet need to break this silo and bring technologists and AI and modelers to, for example, build multiscale models of biomolecular interactions between cells and tissues and over time scale. And in that way, we'll have a much better, deeper understanding of not only aging and disease process, we may actually find novel entry points or intervention points for medical intervention or lifestyle intervention. At the other extreme, For example, we know now access to light during the day can reduce depression, improve mental health to a great extent. And access to darkness at night, I would say, is a universal human right. And having a cooler temperature at night to sleep well is also a universal human right. But with global warming, there is a challenge to even get the basic necessity of a good night's sleep. So now there is a challenge for engineers to come up with low-cost sleeping pods for low-income, low SES group to even have access to better night's sleep. And also for engineers to now come up with better design to use glass as a structural load-bearing element so that we can allow more light to come to living rooms and office buildings during the day to improve mental health. So we got to kind of think beyond our box to brainstorm and bring new ideas and break silos and expand this discussion of longevity beyond biomedical researchers. Thank you.
Thank you. Marge?
Great, thanks everyone for the great discussion. One of the things that I found most exciting in this discussion is to look at the examples that have been presented by our speakers of what I would call successful problem solving, as Michelle Grimm had pointed out, not just creating a new technological system, but actually looking at it from the perspective of solving the problems that involve both technology and people. And I hope, and I'm talking about the systems from Finland and from Singapore that really sound exciting. And I'm hoping that we can take a further investigation of those and use those for examples and making the case of how we need to expand those and create our own version of these in other parts of the world. The other thing that I found kind of intriguing is we were talking on Tuesday about how science and technology could be combined, how we could really leverage both of these together. I was thinking it'd be interesting to look at a deeper dive into those people that have actually successfully achieved healthy longevity, such as the populations, the so-called blue zones and other areas where they have been able to do that, and take a look at it from a multi-perspective basis. Look at the science, look at their behaviors, look at the nutrition, and look at the environmental conditions. And can we learn something new that can help us moving forward to figure out how to actually achieve healthy longevity for a larger population?
Thank you very much, Marge. Anna Maria.
Well, thank you so much for this very animated discussion. And I just want to add 2 cents about something that I don't think has been discussed yet, but I think it's important. So we've been talking a lot about public education that is really essential. But I think we should also start thinking in the trainees and the future generations that are going to take these programs that we are trained to develop, or these interactions. Because if you think, there is still very few graduate programs, even in biology of aging. You can count them in our country with one hand. Our medical curriculum doesn't necessarily have geriatrics until you really specialize. And I think it's important to make young people that not necessarily are thinking about aging to start thinking about aging and try to be creative in ways to incorporate them in this kind of discussions. I think they might have a lot of energy and good ideas to contribute. And I think to fulfill this idea of diversity and people identifying themselves with part of these professionals, I think it's going to be very important to keep also in mind the training of the next generations and incorporate this diversity that we've been talking about.
Thank you, Anna Maria. Felipe.
Yeah, I think Anna Maria more or less said what I was planning to say, actually. I think training is very important, but it's not just the new generations of researchers and people in our field. It's actually educating the public. There's no way there's going to be change in the way the NIH is organized, for example, unless the public starts changing. And the truth is, I think we all agree that we are at a turning point. We are at the point in which a lot of people, not just us, a lot of people are realizing that the system that was so successful in the 20th century in bringing up higher health and longevity is not going to work with the chronic diseases that we're facing now. I think that there's a lot of realization of that. And in fact, I have to say that this issue of the focus on diseases, I used to joke all the time when I was at the NIH that I had been duped because I was told that I was going to work at the National Institute of Health. And in fact, I was working at the National Institute of Diseases. And it's not the same. So this has been happening along, but how we're going to get that to change? It's not going to happen from inside the NIH, I can tell you that. It's going to happen only if there's a lot of pressure from outside. So I think educating not just the new generations, but also the media, the Congress, the investors even, we had to have a better outcome to the public so that people can listen to our story. I mean, my experience has been that when I explain the concepts of neuroscience and things like that to people, people get it right away, okay? And people from high school get it right away and so on. So it's just a matter of pushing it out so that it gets there. And I think that's an important job that we have to do.
Yes. I like the National Institute of Disease as opposed to National Institute of Health.
I did not like it.
Well, one of the most important insights that I've gained from this discussion is that aging is the problem that needs to be solved. I'm thinking of diabetes. If you take diabetic, if you're an ophthalmologist, you say it's an eye disease. If you're a vascular surgeon, you say it's a vascular disease. If you're a cardiologist, you say it's a heart disease. If you're a kidney doctor, it's a kidney disease. Fundamental problem is diabetes, but diabetes is only a biomarker of maybe an even further back underlying condition, which might be obesity or genetically defined. And so all these diseases that we find is, eye disease, heart disease, vascular disease, actually starts out with a fundamental problem, which is obesity. Now, on the other hand, when you talk about aging, the idea that we're trying to address the aging heart or the aging joints or the aging this or that, we may not be focused on the fundamental issue is the inexorable process of aging and the processes behind that. And they manifest in different ways, whether it's bad heart, bad joints, bad brain, whatever. These are only manifestations of an underlying condition, and that really we should focus on how to treat the underlying condition and to take a holistic view, not just a biochemical genetic approach, but really to take it from the standpoint of the way we work, the way we live, the way we operate, and the way our body functions. And if we can take that holistic view, then we can have ultimately a better outcome. I am wondering still, despite some concerns that Victor raised, about when to intervene. Do we intervene now? Or I'm already too old, but if you take my granddaughter, who is 1.5, should we intervene in some way now to address this challenge of aging, so that when she is my age, she'll be a lot healthier than I am and can do a lot more and be much happier? And I don't know how we get to that kind of research. Where is the research opportunity to test these hypotheses of when to intervene? And I think that's going to be a very important challenge for the future. Clearly, there are issues about measurement, about biomarkers, about endpoints, which will be acceptable for registration. The whole issue of regulation is very acceptable for medicines, but is not really applied to devices yet in the same way that they're applied to drugs. And how we think about these multitude of wonderful new inventions that are potentially valuable, but how do we measure the value that they create, and so that we can have a very clear understanding of why we should pay for them and why everyone should have them. And these are many questions that have to be answered in the future. We've come to the end of our session 4. I really appreciate everybody's involvement. It's been interesting because it's been an integrated discussion, crossing all the boundaries between basic science, technology, and implementation science. And it just reminds me that we have to think about all the interventions as an integrated whole, and what pieces fit together, what pieces work together, what pieces work better when they are put together, what pieces are completely independent and can work independently. These are questions that have to be worked out going forward. I'm going to turn now to my partner, Anne, who's the co-head of this workshop. And first of all, I want to thank Anne for the wonderful partnership that we've been able to have to bring this together. But I also want her to invite her to summarize the meeting and close it from here.
Thank you so much, Tachi, and thank you everyone for a really interesting and inspiring discussion again in this second part of the day 2 of the workshop again. So yes, I get the difficult task to summarize, and forgive me for the things I will not summarize. I'll do my best, but what came quite clearly is that yesterday, or at least Tuesday, when Joe Coughlin told us about the wrong story about aging, that's exactly what comes out today, again, massively by everyone. That Joe was saying we look at aging as dysfunction and assistive technologies first, and then smart homes to monitor and manage physical health and safety. But Eric, in the beginning of his intro, was really insisting that we have this wrong view of in healthcare. We look at a human person as a collection of organs that when they get sick, they need to be treated by different specialists. And we have to move towards a holistic approach in order to do that. And John Baird, you were making exactly the same point as well. The disease, the aging considering as a disease is the wrong story. And if we want to change that story, we really require the whole health sector to take a holistic approach and to rethink, re-engineer the systems we work with, or even radically change the way we deliver health and care around the world. But it needs to change from being these reactive care systems to becoming proactive, predictive, and preventive health systems that keep populations healthy. And we've seen with all the technology solutions what a beautiful opportunity we have there to do that. So when we have done it, we then also need to incentivize it, obviously, and the discussion around the reimbursement of it is absolutely key too. When we have another point that was very clear from our first session today, when we have access to these biomedical innovations or the technical innovations, we really need to make sure that we get equitable access to these innovations. And that doesn't only require the health sector to work. It requires a whole of government approach who sets the agenda for enabling an ecosystem that can roll out innovations to the entire populations, regardless where they live, people, regardless what their problems are or ages. And that enabling environment has to cover, for enabling technology innovation rollout at least, has to cover infrastructure, but that only will not do the trick. We need also to have inclusion and digital skills for elderly. Otherwise, they will not be able to benefit from all the technology innovations that will be out there or are already out there. We need a strong governance and regulatory framework, and obviously incentivize new ways of financing this to cross the valley of debt Michelle was mentioning. Besides the whole necessity to work in a needs-driven approach and a human-centered approach, where the end users are actively engaged in the design as of the design phase, but also in identifying what are the processes to integrate these innovations in the current systems. Healthcare, on the other hand, we all know has very little influence on the health of a population, and let alone influence on healthy longevity of a person. It's not about healthcare only. Most of it is linked to all these underlying factors and the lifestyle choices people make over their life course, from kids to now. The question when to intervene with innovations in biomedical science is crucial. However, when to intervene on healthy lifestyles, I think we all would agree that is as early as possible in life. We've seen that if you change children's behavior or teens' behavior, it will last longer, but that's very difficult, obviously. The lifestyle choices have to support a meaningful aging. That was another very strong message that came out. So not a human flourishing approach was, Paul, you made that comment in the chat. I like that a lot. And that's the way we have to look at it. But we shouldn't forget that the healthy lifestyle options need to be available, because people who live in countries where security is an issue, someone mentioned that as an example, you cannot ask them to do physical exercise. People who live in countries where there's 9 months a year winter time and you don't have access to healthy food options, you cannot ask them to choose healthy food options. We've seen that in our work on the ground as well. So you have to have the healthy options available. And again, that's agenda setting by the government. Overall, I believe what we were all saying is that we don't only need a holistic approach for the human-centered healthy longevity, but we need a population-based approach. And Selena was stressing that so much. We need to understand our communities, and we need to take that population-based approach, as aging is much more a factor of the social environment where we live in and all the social determinants and the digital determinants of health than it is of our healthcare system. Again, same message. It's about the environment more so than the healthcare system. But to take that holistic approach and to understand where we can help populations aging in a healthier fashion, we need data. And data currently are sitting in silos, are not often very interoperable, but there are now very clear standards, as we heard loud and clear today, that are absolutely allowing us to share data. And there's fantastic initiatives of data sharing and data collaboratives going on there in the field of Alzheimer, I heard, in the field of mental health, and to make data usable and interoperable. That's what we need to do, to build these standards and use them. But we also need to know what we will want to analyze in our future back vision. Like Tom was stressing in the beginning, if we don't know now what we want to learn in 10 to 20 years from now, we don't know which data we have to collect now. So that's absolutely key as well. let's not forget, as Victor rightly pointed out, that there's also a lot of risks with the use of these innovations and the rollout or large rollout of technologies. We can have really unintended consequences by introducing biases in the algorithms when you have only one population that was used, one type of population that was used for building the algorithm. You can never generalize its result to another type of population, but also the risk that Joe was highlighting yesterday. It's not a future risk, it is there. Our grandmothers and our grandfathers are getting hacked. So we need to build that higher level of security if we want them to trust the systems and the innovations we bring for supporting their flourishing life. And even, let me end by one more point, is even if healthcare has little influence on our healthy longevity, we cannot forget that people at some point in life will end up in the healthcare sector and will need care. Hero, you were stressing that new models of identifying and foreseeing or predicting when people need some care before it happens, before it requires much more work to do the job. So we need healthcare workers, and that's the problem at the moment. So our healthcare workers are not only massively overburdened, and we don't have to ask why. I mean, the world before COVID was already over challenged with the triple burden of disease, infectious disease, chronic disease, and diseases related to nutrition and overweight are really overburdening health systems all around the world. We've seen that COVID massively overwhelms high-income settings health systems too. So our health workers are not only burned out, but we also know we are 18 million short of skilled health workers. So we need to think about them. And we cannot just neglect that we need healthcare also. And that's where, again, technology innovations can really transform the way we will deliver our health services, but it has to also look at the social services. So not only the healthcare, but also the social services. So I would invite us to talk like we do in Europe, not only about healthcare systems, we talk about health and care systems. It's absolutely key that you include social support systems too. And that was another comment I saw in the chat. And apologies if I missed some other comments in the chat, but there were many more. In short, if we want to transform our societies into age-friendly societies, where all people can remain proactive as long as possible and contribute as proactive citizens to our societies, it cannot be done by one player alone. We need to do that in partnership. Partnerships has been a red thread throughout all of our conversations in these workshops, from session 1 to the last session today. We need partnerships to really bring together the different sectors, public, private sector, but also the different disciplines. Disciplines going from health sciences, obviously health and medical sciences, to data sciences, to engineering, to social sciences, to business development expertise, because if we want to roll out innovations at scale, you need to be able to build the business models that go with that. So let's do that, work together towards a better future and a super future-backed vision for our healthy longevity, Linda and John. And John, I want to give the last word to you because I saw you had your hand raised and you didn't get the floor. I'm so happy to see you.
No, it's been a fantastic meeting, and I just want to thank all, Tachi and Anne and all the speakers and everyone who's taken part in this terrific discussion. I think you have inspired us all, and I think that this is a challenge not only for us, but for our children and future generations, because if we don't, if we aren't going to be the pathfinders of setting the North Star and creating that framework, I don't know who will. So thank you very much, Anne, and thank you very much, Tachi. It's been a terrific, terrific workshop. Well done.
Thank you, everyone. And it was very nice to have you with us today. Thank you.